Let's talk about the pseudophakic astigmatism. The cataract surgery nowadays is becoming more of a refractive surgery. Studies have shown that approximately 35 to 40% patients post cataract surgery tend to have a residual more than one diopter of astigmatism. If a patient is asymptomatic and if he has got a residual refractive error of equal to or more than 0.75 diopters, better to correct that residual astigmatism. So what are the challenges of correcting pseudophakic astigmatism is? One is cataract wound healing is unpredictable. Surgically induced astigmatism can be surprising. And most often we don't tend to look at the corneal astigmatism, like things like measuring posterior corneal astigmatism and other things, especially in patients with against the rule astigmatism. The causes for pseudophakic astigmatism could be we don't consider the total corneal astigmatism, or we don't take into consideration topographic astigmatism. We tend to take only SIM-K, especially in with the rule astigmatism patient. SIM-K overestimates the total corneal astigmatism. In against the rule patient, the SIM-K underestimates the total corneal astigmatism. So better to consider total corneal astigmatism than the SIM-K alone. Surgical errors during toric IOL implantation, rotation, effective lens position could be altered in toric IOLs. Suppose a patient has got an eye pre-existing astigmatism, incision-induced, suture-induced, IOL tilt, all these things can contribute for the astigmatism. I tend to follow a rule of 2. That means to say the refraction has to be stable for 2 months. At least 2 months I will wait before I consider any intervention. Errors could be in the form of keratometry reading or in the biometry, incorrect toric calculations, as well as all these parameters, as along with that posterior corneal astigmatism and effective lens position. The patient selection itself could be poor. Suppose if you operate on irregular astigmatism patient, dry eye, zonular instability, or you could have chosen a suboptimal IOL. These are the causes for the residual astigmatism. Toric IOL implantation, inadequate or improper marking, all these things has been addressed by the KP. I will not go into the details of it. Even the rotation can occur. KP stressed on the viscoelastic. Other things one should look for is the hypotony post-operatively, or leakage also causes rotation. Inadequate design or material of the IOL. And the patient factor is especially eye myopes, large capsular bag patients tends to have a rotation of the IOL. What are the treatment options for pseudophakic astigmatism? You have got an IOL related procedures, you have got a corneal procedures. IOL related procedures basically fixated IOL, toric IOL rotation, IOL exchange. In some patient you can do a supplementary sulcus placed phakic IOLs. Corneals, PRK, LASIK and astigmatism keratotomy can be considered. Coming on to the Sulcoflex or the sulcus fixated toric IOLs, the pre-op or post-op refraction should be stable in this patient. The primary requisite is the primary IOL should be capsular bag fixated and sulcus should be free. So the things which you require are the subjective refraction, target refraction, axial length, antechamber depth, surgical induced astigmatism, incision locations. All these things can be entered into these parameters. Then you will tend to get an IOL power of Sulcoflex IOL to be used. Let me show you a small video of a Sulcoflex. Here is a patient had an astigmatism. This IOL which has been marked. Anybody who is well versed with the placing in topical phaco with the foldable IOL implantation can do this procedure. The loading of the lens is similar to any foldable IOL. Once you load that, just inject into a clear corneal incision into the sulcus. Make sure that the primary IOL is well centered. Once you do that, you can rotate the Sulcoflex IOL into required axis or the desired axis, which was already indicated in the nomogram. Once you do that, you can remove the viscoelastic. If you want, you can use an intraoperative pilocarpine also to constrict the pupil. Usually, PI is not required in these cases because there is a clear-cut space between the primary IOL as well as the Sulcoflex IOL. So you can dial it into the marked position, preoperative marked position. That's how it's well-centered IOL. This is a Sulcoflex toric IOL from liner. You can confirm the axis also. So toric IOL misalignment can occur if there is a defective marking procedure or manual marking methods are used. But preferably whenever there is a toric misalignment is there, just look into the method in which the marking was used and the technology which was used in the preoperative period. Whether the aberrometry was used or whether the automated system was used or a manual marking was done. Sometimes the patient's eye has to be closely looked at in. Suppose one eye has got a decentered or a misaligned toric IOL, you should be very careful because patient itself is a risk factor for toric IOL rotation. So toric IOL rotation is a very straightforward procedure. You can use any online toric calculators which are available, which detects the degree of rotation which has to be done. So here you can, once the calculation mark is done where the IOL is currently located, mark how much it is necessary to rotate, and you can rotate the IOL easily. But it is easier to do in the early post-operative period than in the late post-operative period. Coming on to the corneal procedures, the PRK is the commonest and simplest of the procedures. You can correct low levels of astigmatism. But one thing you should remember is before touching on going for a corneal procedure, please look at the posterior capsule. If the posterior capsule is thickened or caused a striae or something, just do a small opening in the posterior capsule, because some of the symptoms may disappear by doing a simple AIOC capsulotomy before doing a PRK. PRK is difficult in older patients because they tend to have an irregular thickened epithelium, which may alter the refraction, and they could have associated systemic disease like diabetes or comorbidities like lid laxity. All these things contribute for the complications associated with PRK. Other thing is there is a mild to moderate pain associated with PRK, and there is a prolonged visual recovery. And the other thing is, if there is a prolonged visual recovery in a treated eye, suppose the patient has got a cataract in other eye, the visual rehabilitation or ambulatory vision could be difficult in these patients. So one should be very careful in such scenarios. Other thing is one may need not have access to excimer laser in all the settings. LASIK has got advantages, faster recovery, but need to be careful in older patients. IOL exchange definitely should be considered. One cannot do an IOL rotation, or if the corneal procedure is contraindicated, you can do an IOL exchange procedure. IOL exchange is definitely, whenever you want to do an IOL exchange, please go through the previous case sheets of the original IOL and whether the preoperative astigmatism are with the rule or against the rule, and current position of the toric IOL should be noted. Small, large capsular excess, fusion of the anterior and posterior capsule, or if there is a tear in the capsule, it could be a risk factor for IOL exchange. The another corneal procedure which helps in the correcting astigmatism is astigmatic keratotomy, where we make in peripheral arcuate incisions to cause a microincisional gap, which causes the flattening in the steep axis. It is a very cost-effective, accurate, and easy procedure. The patients with myopic astigmatism are the ideal patients for astigmatic keratotomy. So what you require is basically preoperative refraction, corneal topography, astigmatic keratotomy in nomograms. You can use the diamond blade for a fixed depth of around 600 micrometers. You can do on one side or both sides depending upon the residual astigmatism. And younger patients, you tend to have a longer incision when compared to the older patients. Let me show you a small video of an astigmatic keratotomy, where an arcuate incision is being done in the periphery beyond the 8 mm clear zone. It is done on both the sides using a 600 micrometer fixed depth diamond blade. You can clearly make an arcuate incisions. So it causes a gaping in that axis, whichever you can extend the length of the axis, arc and other thing depends upon based on the nomogram, you can do it out. You can use a femto laser to create an astigmatism keratotomy, that is called femto laser assisted arcuate keratotomy. Sometimes you can avoid the surface and you can do a just intrastromal astigmatic keratotomy, which will be less invasive when compared to the conventional femto laser assisted. This is a video showing an femto laser arcuate incision which is being done. So it does help in correcting the astigmatism. Rarely in some scenarios, like in this patient with an post-RK, we had a residual spherical as well as cylindrical error. You can use a supplementary phakic IOL into the sulcus and align into a proper axis to get rid of the pseudophakic astigmatism. Chinnappa will be speaking to you about the phakic IOLs. I don't go into the depth of this video. So in conclusion, evaluation is a key and to plan treatment for pseudophakic astigmatism. Corneal or IOL procedure you can choose based on the evaluation. Sometimes both the procedures, corneal and IOL, has to be combined like bioptics to, in extreme cases, to tackle the pseudophakic astigmatism. Thank you for patient hearing, and thanks for the opportunity, Dr. Krishna Prasad and AOS Scientific Committee. Thank you, one and all.